Hi, Mike Gibson, Shaoping Nie, and Gilles Montalescot, and we're talking about a trial looking at prolongation of anticoagulation after primary PCI, the right trial. Talk to us a little bit about what you did and what you found.
Okay, thank you very much. Thank you for having me. And first, the RIGHT trial is an investigator-initiated multicenter randomized double-blind placebo-controlled superiority trial collaboratively designed by two academic research organizations, the CREATE group in China and the Action group of France. And we're very happy to have Professor Montalescot to be our scientific director. So our trial was aimed to test whether routine use of low-dose anticoagulants such as UFH, fractionated heparin, enoxaparin, or bepirovirine were superior to placebo after primary PCI for STEMI in contemporary practice.
And tell me about, how many patients you studied and what you found.
Okay. So in this study, between January 2019 and September 2024, 2021, a total of 2,999 patients with STEMI undergoing primary PCI were enrolled and randomized. And the trial was conducted in 53 centers in China. And for the major results of a study, I have to conclude that first, among the nearly 3,000 patients randomized to post-procedural anticoagulation or placebo, the primary efficacy endpoint occurred in 37 patients in both the PPA, that is post-procedural anticoagulation, and the placebo groups. So the rates are just identical. Major bleeding didn't differ between the PPA and the placebo group, globally and within anticoagulant groups. However, a significant interaction was observed for the types of anticoagulant and the primary endpoint. The p-value is 0.015. So we have to interpret these results with caution, just because this is just an exploratory study in our trial.
Gilles, what do you think? I mean, 3,000 patients, pretty big study. Talk to us a little bit about your interpretation of the results.
Mike, it is a big study, really, in primary PCI. Trying to answer an important question with currently no recommendation in the guidelines. Shall we continue anticoagulation or not when the patient gets out of the cath lab? And many of us do, but we have no data to support this. And of course, it's even more complex because we have several anticoagulant drugs available: bivalirudin, enoxaparin IV, unfractionated heparin. So what shall we do? And clearly what we try to do with Professor Nie and colleagues in China is to answer this question. So clearly, globally, for the global population, there is no difference of prolonging anticoagulation or stopping it at the end of the procedure. But clearly, we have a p-value for interaction, which is highly significant when we look at the three drugs used in this trial: enoxaparin IV, bivalirudin IV, or UFH IV. And it appears that the data with enoxaparin looks significantly better than placebo when you push the anticoagulation. However, it was not randomized. This part of the study was not randomized. Each center had to pick one drug and its placebo. And of course, it was fully blinded, but at the level of the patient, it was not randomized. So globally, the message is prolonging anticoagulation. We find no significant effect on safety or efficacy, but there's a question mark here on enoxaparin, which tends to show better results. So we need other studies.
Mhm. Yeah, back long ago in the Extract TIMI 25 trial, I reported on the PCI cohort that you did see better benefits with enoxaparin over heparin in those people undergoing PCI for MI. It's an effective drug in that setting, and it sounds like maybe prolonging it would be a good idea. With bivalirudin, I'm interested, Jill, because that had always been one of the results in the bivalirudin trials was prolonging the infusion might reduce the risk of stent thrombosis. But you didn't see that here. Is that true?
Yes, we didn't see a benefit of prolongation with bivalirudin in this study, just like with unfractionated heparin. And you rightly mentioned your study is the Extract study with very important information on enoxaparin in this type of patient. We should add on top of these studies the ATOL studies that we conducted in primary PCI with the exact same regimen of
Mhm.
IV enoxaparin plus 40 milligrams of enoxaparin afterwards, which was successful against UFH. So there are several lines of evidence suggesting that there may be something here with a prolongation of enoxaparin at a reduced dose. It's not a full dose, it's a
Right.
reduced dose of enoxaparin.
So what's next, Jill? Are you going to do a larger follow-on study, perhaps focusing on enoxaparin? What are you planning?
We need to discuss that with Professor Nie, and clearly we would have to redo the study now. We would probably like to do a similar study with enoxaparin only to prolong the treatment. But, we need more data for sure.
Well, Dr. Nia, congratulations. Amazing work. When I look at clinicaltrials.gov, I got to say, many, many, many of the STEMI studies these days are coming out of China. You're enrolling large numbers of people very quickly, really contributing important information about how we manage our patients. Very well conducted study, Dr. Nia. Congratulations to you and all your colleagues. Thank you so much.